Hey everyone, welcome back to the show. Today I'm lucky to be joined by my guest, Natasha Wilch, out of Vancouver, British Columbia. Thank you for joining me today.
My pleasure. Thank you for having me.
So you are a physiotherapist up in British Columbia focusing on concussion rehab, is that correct?
That is correct. Yeah. So we have a multidisciplinary clinic, but predominantly concussion and neurological rehab is our focus.
Okay. And then our major topic of discussion today is going to be fall risk and concussions and how those two interplay and what to be mindful of there. But before we dive too deeply into that topic, can you talk to us a little bit about your journey and why you're so interested in helping those with concussion?
Yeah. So, it wasn't a clear path or a straight path. I started practicing physiotherapy in 2011, and I didn't really know exactly what I wanted to do. So like most new grads, I started in public practice and worked in the hospital system. And there I got to work a lot with acute neuro and orthopedics and pediatrics and emergency medicine. But the unit that I really loved was the rehab unit, particularly working with a lot of strokes and spinal cords and people rehabbing from a neurological injury. But I didn't know anything. And I felt pretty terrible as the physio who was supposed to be helping people get better, who knew nothing. And so I very quickly started taking courses in neuro rehab and rehabilitation and fell in love with it. The intricacy of the nervous system and the brain and how it is so intertwined with everything else that we do, I like challenge. And every single person was a new puzzle. And to get to be a part of their life-changing moments for many of them, you think of your stroke clients who take their first steps again. You think of your spinal cord clients who are able to stand. You think of your concussion clients who are able to return to the things they love to do. When I moved to Nanaimo, BC, which is where my clinic is, I didn't know anybody. I had a 4-month-old son. We moved because my husband got transferred for work. And so when I tried to figure out what I was going to do, obviously neuro rehab was a big passion of mine, and I wasn't doing concussion yet. And I started as a mobile business, just driving to people's houses, giving them therapy in their home, and then very quickly opened a small little brick and mortar clinic. And because I was truly one of the few neuro people in town, all of a sudden I started getting concussions. And I kind of, again, was like, I know a little bit, but I didn't know a ton. And it kind of took me to instantly, when I don't know something, I figure it out. So I started taking courses again, and then dove down the rabbit hole, because where I found what I was doing before already a puzzle, concussion was a whole new ball game. The intricacies, the understandings, the layers, the uniqueness to each person, but the similarities, you have to apply it a new lens. And so for me, again, I just started diving down that piece. And I've had a minor concussion. I don't have PCS. I haven't recovered from PCS. I do have a close family friend who had a head injury, who went through some rehab, and understanding and experiencing it from a family member's side of, the volatility in temper or the zoning out or some of those things. And I didn't understand what was happening at the time. And to help people better understand that process drives me as well. But honestly, it's my clients. When they come and they first get here and they can't function and they're dizzy and their head hurts, and we can get them back to their life. Like, I am that therapist that claps for joy and cries. Like, I wear my heart on my sleeve. And we did a gala last year and I was sharing some of the stories, and there was one gentleman, he was my very first concussion client, and he sent me an email after our rehab was done. And he was a big rig driver, but because of his vertigo and his dizziness and his headaches, he just couldn't do it anymore. And he sent me an email, and it was him standing in front of this new big rig truck. And all he said was, he's like, "Thank you for everything you did." He's like, "Without you, I wouldn't be here again." And I just started bawling because he got his life back. He got to do the things he wanted to do. you think of some of your other clients, and you will have experienced this as well with in the treatment that you do, but she was a calligrapher, and she's a beautiful artist, and she hadn't been able to do it for 18 months because she couldn't focus her eyes. When she did, she had the headaches, all of those symptoms we're so used to doing. And she came into the clinic one day and she handed me a card, and she had drawn this beautiful picture of a horse and like wrote my name and wrote it out. And it's the first thing she'd been able to do in 18 months. And so for me, the thing that keeps me going is the fact that I can work as a team member with my clients to truly help them live their lives again.
Mm-hmm.
So, yeah.
And I can obviously tell that you feel incredible pride in what you do, and a sense of reward and fulfillment in being able to help your patients. And I feel the same. And I think you kind of touched on something that's been a very universal element to what a lot of people talk about on the podcast, and that pretty much every head injury is different, and you really have to study and you have to keep working, and every new patient almost presents a new challenge that you have to research and take additional courses for to figure out. And that just makes you better and better and more adept to help the next person. So
absolutely
great that you're
I feel like you think you got it, and then you realize you don't.
Yeah.
And it's the clinicians that are the forever learners are the ones, I think, who do the greatest things.
Yeah, that old cliche, the more I learn, the less I know.
Absolutely.
Feels very relevant to this.
It's so true.
But so going back to our prime topic today, looking at fall risk and how that could potentially lead to concussion. Obviously, something a lot of people in our field look at is balance and stability and gait. What are some ways that you want to assess balance, and what are some risks that people with, I guess, altered balance should be thinking about?
Yeah. I mean, I think it's when we think of falls, we tend to think mostly in our elderly population, right?
Mm-hmm.
So, I mean, we know that they are the leading cause of injury altogether in the elderly population. And if you think of someone who, like 90% of hip fractures come from falls. But if you think if someone has the force to fracture their hip in a fall, there's quite the possibility that they've also given themselves a concussion, right? So we know now that you don't need to hit your head to have a concussion. And so I think before, person didn't hit their head, it wasn't really thought of. But then what you would notice down the road is that people start saying, oh, she's more forgetful, oh, her dementia's kicking in, things are ramping up. And I think that that's where, as a medical group, we need to pay attention to those things. So in terms of assessing fall risk for people, I think across health professions, doing what we can to mitigate that is so important for quality of life, longevity of life, a healthy life. And actually, I ran a fall prevention clinic, not a whole clinic. We did like a weekend clinic in Nanaimo, because it is multifactorial on what's going to contribute to someone's falls. So when we're thinking of our elderly population, and predominantly what we do in the terms of functional neurology and chiropractic and physiotherapy, we tend to look more at balance and gait and those things. Those are two factors that we look at. But you also need to look at things like medications, looking at things like blood pressures and heart rates, looking at home environment, right? So what we actually set up that in Nanaimo, it was probably a couple of years ago now actually, is we opened up this fall risk assessment, and we had people come and we put them through a circuit, and they got to connect with a physiotherapist or a nurse to talk about health history. So looking at, do they have a past history of head injury? Have they had other gait issues? Do they have other comorbidities that are also going to affect gait? Like Parkinson's is the prime example, right? So we looked at that. They went to another circuit where they worked with an OT to talk about home environment and home setup. So when we think of gait and we think of, we move slower, we have decreased stride length, we tend to because we have decreased bounce, we get lower our center of mass, so we get more flexed and a bit more shuffly. So if you consider the gait aspect of what happens with a lot of elderly, then you take that to a home environment. Well, do they have a lot of stairs? Do they have a lot of rugs that are free? Do they have a lot of stuff in the way that they have to navigate and maneuver? So looking at those pieces, because that, yes, the walking is going to, and the gait stuff is going to increase their fall risk, but then couple that with their environment and they're even more heightened for fall risk. We had them go to a station where they actually met one-on-one with a pharmacist to do a medication review, because how many people do we see in our clinic that are on a slew of medications that haven't been reviewed in ages, right? I mean, there's so much what happens today, especially with people, especially, I don't know what it's like in the US, but in Canada, it's incredibly challenging to get a general practitioner. And so a lot of people will go to a walk-in clinic and they'll get followed up by a physician in the place. So they get prescribed a new medication, and previous medications or the medication list isn't always reviewed. So those interactions, whether it's leading to, like, the medication interaction can lead to orthostatic hypotension, whether the medication's leading to dizziness or headaches, right? So that's another factor in that piece of things. And then in that fall risk, we did a Berg balance test. And a functional gait index to kind of see. And so then we took all of these factors that contribute to someone having a fall risk score, and then we actually sat down and gave an action plan. So it was like, you know what, your balance is not so hot. And we looked at what could we provide them in terms of interventions, or who could we connect them with in the community to help mitigate and to help improve their balance and their gait, which would thus then mitigate their fall risk. We connected them with home-based OT to actually be able to book an appointment to go into the home to do a home review to mitigate that risk of the environment. The pharmacist sent notes back to physicians to say, hey, we might want to look at this medication to make sure. So it's important that people realize that fall risk doesn't come from one area, that there's multifactorial. But then there's the also piece that if you have one fall, and especially if you have a concussion from that fall, if that concussion isn't addressed, you're going to be at higher risk because of everything that we know can come out of a concussion as well.
Yeah. Well, I love that you brought that up because, I mean, I think when people see the title, you know, fall risk and concussion, they're going to think, okay, elderly are typically at a fall risk. But I can tell you how many times I've had somebody come in after sustaining a concussion, and the way they fell was because maybe they stood up too quickly and, you know, they passed out and then hit their head. A scenario like that. So, and now we have to treat, you know, maybe some dysautonomia type issues, you know. So the concussion, we know, can kind of perpetuate that too.
Absolutely.
So how do you kind of assess that aspect of fall risk per se?
I think part of it for us is, you know, anytime someone comes into the clinic with, say, balance is their concern, because if someone doesn't think there's anything wrong, it's really hard to get them in the clinic to do an assessment to help improve their function, right? So when we're looking at, when we're assessing somebody, we're assessing the complete picture. So someone might come in with saying that their balance feels wonky and that's why they're here. We're not going to assess just their balance. We want to figure out why their balance is wonky. And so, you know, and many people know that balance it comes from, you know, you have your visual system, your vestibular system, your somatosensory system. Like you talked about, the dysautonomia piece is going to factor into that. So you can't just test someone's balance, say, okay, so you're wonky on single leg stance, we're just going to practice single leg stance, because that's not going to generate change. So when someone comes into our clinic, we are assessing all the components that then contribute to someone having poor or good balance. So looking at that vestibular system, looking at the visual system, looking at the autonomic nervous system, and are they experiencing dysautonomia, because we know that's going to be a huge piece of it. And then figuring out where their deficit actually is, treating that, and then integrating it back into functional tasks and balance tasks.
Yeah. And not to mention the ocular motor system as well, and issues with eye movements and tracking and all these other components that keep us upright and horizontal.
Absolutely. It's that whole, if your body doesn't understand where it is in space, and it's always trying to guess where space, you're always going to be trying to self-correct, which is going to put you at more risk. If you don't know where things, I mean, you think of why someone falls, potentially it's a dysautonomia thing. Have they tripped over something? Have they bumped into something? There's so many different reasons why somebody could fall. Was it an unstable surface? Your body's going to respond to keep you, exactly like you said, to keep you upright against gravity differently. It's going to draw on different systems in these different scenarios. So I think as a practitioner that's working with someone in balance and falls and at any age range too, because we also know that once you have a concussion, you're more susceptible for further falls, you're more susceptible for further musculoskeletal injury, and that doesn't necessarily factor age into it, right? Like how many of our concussion clients who may have had their concussion, so an example, she actually fell on the ice rink and didn't hit her head at all, but got a concussion. And then part of what was affected for her was her awareness of space. So then in terms of hitting objects and those sort of things, so it perpetuates you for further falls, the cognitive piece and all that realm of things too. So.
Mm-hmm. And that's a good point. You said she hit her head and that perpetuated the risk of further falls, right? So not only do we have to think of, falls leading to concussion, but then concussion potentially leading to additional falls. And yeah.
Absolutely.
So can you walk us through, I guess, a process if I'm a patient and maybe I've had a concussion, we'll say from a fall, what does it look like coming to you, and what does the rehab process kind of look like? If you could give us some generalities.
Yeah. So typically, so you're going to come to the clinic. So my clinic's in Nanaimo. And so if someone comes to the clinic, it always starts with an initial assessment, which honestly, to go through the whole thing takes a couple hours. So we'll look at, like I said, we look at the different components. So we're always going to start with a history and a medical history and find out collect that information. We're really big on objective outcome measures. So we kind of have our staple, we use the Rivermead. We pull in the Coppus 31 if we're looking at dysautonomia. We look at the BIVIS to look really closer at that ocular motor stuff. So having those outcome measures is really nice tool, because as you will know, sometimes as we recover from concussion, we forget where we started and we kind of forget the change that we have, because it's not a light switch that switches on overnight for a lot of people. And so being able to go back to these outcome measures to see the difference, and those outcome measures are also going to help guide my treatment, right? So if we do the dizziness handicap index, for example, and they're ticking questions like, when I roll over in bed, I get really dizzy. When I look up, I look dizzy. When I look to the right, I look dizzy, and it's vertigo. I know I'm going to scream for BPV pretty quick, because if BPV is their whole reason of vertigo, then we can fix that quickly, right? So there's a series of just outcome measures that we do. And then we use infrared goggles to get a better take on eyes and vestibular. We use the right eye to assess ocular motor, functional ocular motor and task tracking and things like that. We don't have a posturography system. We use the posturography that's linked in with the NSI. And then I also use Brain EQ just to get an idea of their balance score for themselves. But we'll do it on old school fashion too, with foam and stuff like that. We do have the Virtualis virtual reality system. So I like their subjective visual vertical for the client to be able to see where they thought upright was. Anything that you can do, I find, in an assessment and in a treatment that helps demonstrate to the client where they are in that moment and how they're performing, and to see themselves doing something is so powerful. And it makes them truly feel like they're a part of their rehab team. And that's crucial, because if they're not an active participant, you're not going to get the goals that you're after. And then we'll do a clinical bedside exam. So looking more at, do we need to do some testing for dysautonomia, ocular motor, reflexes, somatosensory testing, and that stuff. So we're doing a large test to get a picture on where exactly is the issue happening, where is the dysfunction. Not everyone gets every assessment, obviously. It's always based on kind of where things trending, and then the client's goals. So we always want to relate back to function, because if I can't explain to a client why it's important that their vertical smooth pursuits don't work, they're not going to do their exercises that we assign. It needs to be salient to them, and it needs to relate back to their goals every single time.
Mm-hmm. Absolutely. Yeah. Absolutely. And in addition to the work you do in person in your clinic, you're also doing some great work with mobile I guess means to help people
online.
Online to help people with concussions and help them navigate the complicated world that is concussion management.
Yeah, so I do that in two different ways, really. So, one way is I do one-on-one coaching for people, and the one-on-one coaching is more because my physical therapy license doesn't let me treat beyond the borders of where I'm licensed. So I'm licensed in BC and the Northwest Territories. So via telehealth, because we do telehealth as well in my clinic,
Mhm.
I can do again an assessment, oculomotor assessment, and give oculomotor exercises and gaze stability exercises and all that. In an area where I'm not licensed, I'm more restricted in the therapeutic things I can do. But as a coach, I'm more interested in helping people navigate and figure out where their symptoms are, where their biggest issues, to guide them and coach them on more the lifestyle factors of things. So do we look at planning and pacing? What is your nutrition like? How is your sleep? And those pieces that I can help with. And then I connect them with a practitioner who can really do those things and get the diagnostics and do the specific rehab that they need. So it
Mhm.
absolutely is a complement and an adjunct. Does not take the place of rehab. And so that's one-on-one coaching. And then what I do, Molly Parker and I are partners in our company called Concussion Compass. And Concussion Compass is something that we are both incredibly passionate about. Like you said, there's so many people out there around the world who have concussions and just don't even know. They don't know where to begin.
Mhm.
And Compass is meant to truly help you navigate the messy world of concussion. We were talking about it this morning actually, and we're like, Compass is like if you're going on a trip and you have a compass is your backpack, and
Mhm.
in your backpack you have, if you're hiking, you have a water bottle, you have some sunscreen, you have a hat, right? You have the things that you need for different points of time along your trip. And that's what Compass is. So Compass as a whole is like your backpack, but then in the backpack are different tools and tips and things that you might need to use along your journey.
Mhm.
So if you're having extra headaches and you're trying to go watch the headache module. If you are going to, you're going to go see your Aunt Joan in London, that's my auntie in London. I might go pull in my backpack and pull out my packing tips and my tips for travel,
Mhm.
right? So it's literally meant to be an adjunct. It's meant to be a tool in the toolbox. And then the same thing, our big thing is connecting people with awesome practitioners to do that one-on-one rehab piece, because again, it doesn't take a spot of rehab. It's meant to support you, provide you tools, education, empowerment. Molly and I do live mentorship calls, and we have guest experts that come on and share the world of their knowledge. I mean, you live this world every day as well, so we know that there's amazing, passionate practitioners out there who are hard to find, or it's incredibly challenging to get in to see them because they're so busy.
Yeah.
And so what we do on Compass is we really want to highlight these amazing people to our members, but give our members access to their knowledge. And so we have a guest expert once a month, and they'll come teach kind of on their topic for part of the call, and then it's an open forum for questions and discussion, and it's a really interactive space and a sense of community and safeness for people living with PCS. So we're pretty we're pretty passionate about it.
Yeah, I think that's great. And, there's so many people who are looking for those kind of services, and they just don't know where to start. So many
Exactly.
people struggling with PCS, but there's only so many people who are actually managing uh, this issue. And it's great that you're able to guide them and give them tips along the way. I think that's a much needed thing in this world.
Thank you. Yeah, I love it. And the members
Mm-hmm.
that we have so far, so we only launched it about 3 weeks ago.
Mm-hmm.
But we have a really awesome group of members in there right now. And the nice thing is, you don't get to control when you get a concussion. And so membership of the program and the platform never closes. So people can register at absolutely any time.
That's great. That's great.
Yeah.
So, Natasha, we are just about out of time, but I wanted to make sure to leave room at the end for you to talk about anything we may have forgotten to mention throughout the podcast, or anything that may have come to mind.
Yeah, I could talk about this topic forever.
Yeah.
So, but I feel like we kind of hit on some of the high points. In terms of falls, if there's practitioners listening or families are listening, just recognizing that there are multiple things you can look at to mitigate your loved one's fall risk, whether they are younger or older.
Mhm.
And that in terms of, again, brain health and quality of life, it is really important to work to do that. And in terms for the PCS population, there's help out there. you don't have to live with the symptoms you have. There's amazing practitioners who can help you, and then there's groups like Coppus that are here to support you on that journey as well. So yeah, thank you so much for having me.
Of course. Thank you for being on. And then if people, one more time for those listening, can you give us all the places that people can find out more about you and the projects you're working on?
Yeah, so my Instagram is at natasha.wilch. My email address is hello@natasha.wilch. Concussion Compass the website is www.concussioncompass.com. And then there's a get in contact page through there as well. So those are probably the best ways to reach out and connect with me.
Awesome. Well, thank you again for being on today. This was great, so yeah.
Thank you.
Yeah. So from your host at the Neuro Wellness Podcast, be well.